of Haemophilus 1, what is it called?
Influenza.
Yeah, Haemophilus influenza vaccine. So this reduced the occurrences. It's 95% less than it used to be. And then when the child presents with epiglottitis, it could be caused by Haemophilus influenza, even though they were vaccinated, believe it or not. And then there's another organism that likes to sit on the epiglottis, and that's a beta hemolytic streptococcus. So that can cause the epiglottis to swell also. The signs of epiglottitis are, because the epiglottis is really swollen, the best way for the child to breathe is leaning forward. It's called a tripod position because they like to lean forward on their arms and extend their neck. And what they're doing is trying to maintain their airway without realizing it. And so they'll have the typical position of leaning forward with their neck extended. They're going to have real difficulty swallowing because the epiglottis is so swollen. And because they have difficulty swallowing, they have a lot of secretions in their mouth, and it tends to come out, and so it looks like they're drooling. All right, so the clinical presentation is abrupt. It's associated with high fever. That's different than with croup, which was associated with a low-grade fever. Do you know if you have a low-grade fever, how many degrees Fahrenheit is that? Is 100 considered low-grade?
I thought it was, yes.
What about 101?
I feel like that's beyond.
Do you? Yeah, usually 102 is when you consider it a high fever. 102 and higher is high fever. The child will complain of a severe sore throat. They'll have a muffled voice. Muffled because the epiglottis is large, and talking around the epiglottis causes that muffling sound. You'll see drooling. They'll be short of breath. They'll be sitting in a tripod position. So in order to diagnose epiglottitis, you see a thumb sign for the epiglottis on the lateral neck x-ray. So this x-ray is taken from a side view, and it shows the epiglottis looking like somebody's thumb was in the picture, and that's just from the swollen epiglottis. So the thumb sign is typically referred to when you're taking your national exam questions. The child presents with high fever, a muffled voice, they're sitting forward, a lateral neck x-ray is taken, and it shows a thumb sign. And all of those are describing acute epiglottitis. So this shows a child. You can see how their neck is extended a little bit. The mouth is open, just trying to get some air. The child assumes the characteristic sniffing position to maximize the patency of her airway. And here's another x-ray showing the thickness of the epiglottis. All right, so establishing an artificial airway just to sedate the baby and intubate in the ER is kind of risky Because putting the laryngoscope in the mouth, into the back of the mouth, and to lift the epiglottis out of the way to get the tube in, can actually immediately cause more swelling of the epiglottis, and it can completely occlude the airway. So instead of intubating these children in the ER, they're taken to OR, and it's done under general anesthesia, where everything is a controlled environment. So if they can't get the tube in right away, they can trach the patient. All right, so you have to avoid any procedure causing anxiety, because with anxiety becomes more respiratory distress. So to keep the baby, the child, I don't know, comfortable, you can use a cool aerosol that helps to soothe the upper airway. Even drawing blood sometimes can cause them to want to cry, and that can cause more distress. So if they need mechanical ventilation, it's just 24 to 48 hours to get the swelling under control. Again, it's with antibiotic and with systemic steroids. So you added steroids to your notes because it only lists antibiotics here. All right, I have a question. How can you determine if the airway is patent prior to extubating the child?
Minimum leak test.
So you can deflate the cuff, and you should hear air leaking around the endotube. So if your airway pressures are about 20 centimeters of water, and the cuff is deflated, when a breath goes in, and 20 centimeters of water pressure is generated, should you hear air leaking around the tube at that point? Sorry. That tells you that the airway swelling has gone down, and if you take the tube out, then air can't get past the upper airway. All right, you have a 3-year-old child in the ER. She's pale with a temperature of 103 degrees Fahrenheit and in marked respiratory distress. Now the word marked is something that is used on your national exam, and when you see the word marked, you're supposed to think something immediate needs to be done to establish an airway. So marked respiratory distress is the same word as we would use when we say severe. All right, she's sitting forward, drooling. You have just placed a cool aerosol mask on her, and a lateral neck x-ray has been taken. Your next step would be to A, use a tongue depressor to view the epiglottis, or B, transport the patient to the operating room for intubation and possible tracheostomy. B?
B. Yeah.
Correct. The answer is B. All right, so moving down lower in the respiratory tract, we'll talk about airway obstruction in the lower respiratory tract. And one that is really big is RSV, or respiratory syncytial virus. The word syncytial comes from how the virus causes destruction to the airway. So the way that the virus invades the cells in the airway, it causes the cells to lose their cell wall. So when you're looking at a microscope, all the cells look like they've been fused into one big cell. The neighboring cells fuse together to form a massive protoplasm with many nuclei, and that's where the word syncytium came from. So respiratory syncytial virus causes this type of destruction to the upper or to the lower airway. The virus spreads along the respiratory tract by cell-to-cell transfer. There will be edema of the bronchiolar walls in the submucosa. There will be sloughing of necrotic tissue, and there's going to be an accumulation of mucus. All of this is going to lead to a decrease in airway lumen size. So you have a lot of swelling, you have mucus, you have debris from the cells that were destroyed from the virus. And then some more notes to add. The virus is highly contagious. The virus is highly contagious. It lives on hands and other surfaces. It lives on hands and other surfaces. So the patient needs to be placed in minimum contact isolation. And with contact isolation, what sort of barrier protection do you need?
Mask?
Glove. Gown. Yeah.
Gown and gloves for contact?
Oh yeah, sorry. Mm.
So yeah, contact isolation is usually the type of isolation. However, if you're within 3 feet and they're going to cough on you,
It's on you at that point.
Ask.
you need a mask.
Yeah.
Yes. So it's best when the kids are in RSV, contact isolation for RSV, that when you're doing the breathing treatment, that you wear a mask. I know in PICU, they'll separate the therapists that are caring for the kids that have contagious illness from like the surgical kids, because you can carry it on your body. Even if you take your gown off and your gloves off and alcohol your hands, you can still be carrying it into the other room. So usually they'll assign a therapist to, they call it the dirty side, where the kids have a contagious illness, and then the clean side would be the surgical patients. So RSV occurs in children by the age of 2. Most children have had the virus. It can occur with adults also. And it's seasonal. So January, February, and March are when you have the most outbreaks of RSV. Clinically, the child will present with increased work of breathing. You'll see tachypnea, intercostal retractions, nasal flaring, grunting. If they have signs of apnea, that's a sign that they're getting tired. So they're beginning to fatigue and go into respiratory failure. When you listen to breath sounds, you'll hear wheezing, you'll hear diminished breath sounds, you'll hear crackles. The white blood count will be normal. So how is it that you could be this sick and your white blood count is normal? Do you know?
Well, it's not in the blood, it's in the respiratory tract.
Yeah, but you could have infections in other parts of the body, and you'll have a high white blood count. All right, so with bacterial infections, you'll get an increase in your white blood count. But viral infection, you don't see an increase in white blood count.
So just
Have
the
you heard of
difference
this
is
before?
Yes.
Yeah,
Okay.
yeah. Difference.
Just timid.
Yesterday?
Just timid.
She
okay.
was saying it under her breath.
Oh, okay. So hypoxemia from VQ mismatch. The CO2 begins to rise in the blood if the patient becomes fatigued. When you get a chest x-ray of a baby with RSV, you'll see hyperinflation because of the airway obstruction. You may see interstitial pneumonitis, you may see both. Okay, let's see if we can click on this. Nope. Sometimes it lets me and sometimes it doesn't. Where did it go?
Yeah, there's a bullet in front of it, and then it went to Google because of that little bullet. You'd have to put it back in the URL space.
Copy that and put it back up top.
Yeah.
Hello.
Do they get permission to record this?
Do they get permission?
Oh,
The glucose was coming in at about 20, and the sugar rate was what, about 60?
All right, so this is the venous blood gas. This is where experience working with babies and children come in hand. When I see something like this, I would have intubation equipment out.
ready.
And they're just like, oh, okay, here's the blood gas. Yeah, baby's not looking so good. And they just, get an IV started, give a nebulized treatment. But yeah, venous blood gas 7.2. That's pretty low.
That's
CO2 79, even for venous, that's high. Really high potassium level. I wonder if they hemolyzed the sample when they were drawing the blood. Glucose is low, so let's give the baby some glucose with the IV. In this case, the white blood count is 18,000. So that's elevated, and yet it's RSV. So that's what's interesting about that.
And it's pulse ox, yeah, very weak effort, the pulse ox was like 60%. And we got a jet nab, got some IV glucose, got some IV fluids.
And you're gonna hear the
3 weeks.
is that his breathing? His breathing?
It's up to 6 times a minute.
All right, so he also has beta
Doing
pertussis,
his belly breathing.
which is bacterial.
Oh, so that's a result of the white blood cell.
Yes.
He was a chest X-ray that's like, so this will be a second jet nab, I'll do a second IV on him. And his temperature was, what was his temperature, guys? 38.1. And his PCO2 was 75, around 75. He gave 7.2 something.
How'd you hear that? That means we're feeling better. Yeah.
That's better.
That's like, oh, okay.
How'd you get better?
He escaped it, I think.
All right, so what do you think about this technique for delivering the medicated aerosol?
A blow by? I would have liked a nasal cannula.
I think that's good.
Is that what you're seeing in PICU?
Well, NICU.
In NICU?
Oh, no, in
They
NICU
do
we have
blow-bys.
AeroNeb.
You do blow by?
In Memorial we have like the AeroNebs. They've been using those now.
AeroNeb?
Intubated?
If they're intubated. If-
Only if they're intubated?
oh, okay. Yeah, if they're intubated, that's what we use. But
So I don't like that they don't have on gloves.
yeah, you're right.
Oh, yeah.
Right, and they have viruses and stuff.
Yeah, you're right.
I did not catch that.
Good eyes.
Such an update.
Yeah, so when you read in the literature, as far as nebulizing via blow-by, it says that the infant gets almost none of the medication. So it's better to have a mask on where it creates more of a reservoir than just holding it up towards the mouth. So they get a lot more with a mask
And they can
on.
rebreathe as well.
Yeah.
Yeah, that makes sense.
Anyway, that's getting off topic a bit.
Little Sam.
I might take that from her.
And then they're supposed to show a second baby.
She's been trying to get the IV for a while.
Something like this for how long?
She just got it a little bit last night, and then stopped. And then a little bit more than we decided.
Constant cough. All right. You run the fever at home?
Oh,
No fever at home. She eating all right?
it's gonna be so bad.
Did you ever turn
Do
blue or
you see anything nebulizing?
episodes of stopping breathing?
Is
No?
there anything?
Is there anything, what?
nebulizing out of that?
I don't know if it was at the end.
Oh, okay. 'cause
When
I
they
was like,
started
oh, where did I
recording.
see the other one was.
Anybody else in the family sick?
Her sister got a cold, I think that's what she got it for.
Okay. And is she in daycare now?
Oh, that's so sad.
Every breath is a cough.
Yeah, so she's really not ventilating that well. What would you want to do in this case? What would you, like, this is really, like, bad.
Yeah, that
Tubal.
continuous coughing. So would inhaled steroid help at this point, maybe, to reduce inflammation?
But not blow by. Maybe like a,
Like have a mask
Mask
on so
on.
you're getting more of the medication?
yeah.
And I wonder how well the baby's being oxygenated while getting the treatment too.
Yeah. So maybe bump up your O2 at the time.
Yeah.
So now this is nebulized epinephrine. We're doing, how much we're giving her?
2.5
Of the 1 to 1,000.
1,000.
All right. All right, her coughing slowed down, and her, she seems to be breathing a little bit, she's still breathing very fast. The abdominal breathing, but I don't see as much in her costal or subcostal retraction.
So it looks like that's acceptable. I'm gonna finish off this handout before you guys go to lunch. All right, so in order to tell if the virus is in the body, a nasal swabbing is necessary. And try to get a nasal swabbing from an infant or a young child is very, very difficult. They don't want you swabbing their nose. So it almost takes 3 people to hold the head still and hold the arms down and the feet down to get the nasal swabbing. It's then sent to the lab, and then within an hour or so, you get the result of whether the virus is there. Treatment is supportive with oxygen, adequate hydration, bronchodilators, racemic epinephrine. Currently, there is no vaccine for RSV. There is something that can be given, though, and it's called Pelvic.
Oh, television.
So this is a series of monthly shots that are given to the high-risk babies. So any babies that have had cardiac problems or congenital defects, they want to do this prophylactically, because usually those babies have depressed immune systems because of all the stuff they're going through. So they need something prophylactically. So they'll give them shots once a month during the high season, December, January, February. Or was it January, February, March? January, February, March. Tracheomalacia occurs because the cartilage in the trachea is real soft and it's highly compressible. It becomes damaged with the positive pressure that we use to ventilate. By putting the trachea under the feelings of positive pressure can weaken the cartilage. The endotracheal tube rubbing against the sides of the trachea can cause damage, and that's what leads to tracheomalacia. So it says for treatment, nothing is listed there. So I have PEEP or CPAP is a way to keep the trachea open using PEEP or CPAP. Also, an airway stent can be placed in the trachea. An airway stent. An airway stent is like it's not made out of wire, but it's made out of something that's firm that can be the support for the trachea. The problem with the airway stent is as the trachea grows, that old stent has to come out and another stent put in place. Yeah, so to stop tissue from growing around that stent, because when you go to remove it, it's going to take tissue with it.
So,
Yeah, I don't know. We need a stent that grows with the child, I guess. Maybe it needs to be like 50% elastic or something.
we need to invent it.
All right, so positive pressure or PEEP, CPAP, and then a stent. Pneumonia mostly affects children less than 2 years of age. 80% of the time it's viral, and bacterial infections are not as common. It's typically, you'll start off with a viral infection. The virus causes the mucosa to be inflamed, and now bacteria can settle in. So bacterial pneumonia is usually secondary to a viral pneumonia. Another reason that bacterial pneumonia happens is from reflux. So if babies have immature, pyloric sphincter on their stomach. They have a lot of the feeding coming up into their esophagus. It can come up into their mouth, and then they can inhale it into their lungs. So if that's happening frequently, they end up with a bacterial infection. So those are the most common. So what are some underlying causes that lead to pneumonia? And I have, do you want to write that question down first? What are some underlying causes that lead to pneumonia? Asthmatic. Reflux with aspiration. And then third, premature infants have, their immune system is not as efficient as a full-term infant. So what could you write? Premature infants, immune system not developed?
Immature immune system?
Yeah, I guess just premature infants have an immature immune system. What is the most common airway illness in children?
RSV.
Other than RSV.
I was going to say RSV.
You were?
Yeah.
Stacy knows.
Oh, she said it.
Oh, did I say it?
Yeah.
Asthma?
I thought, I've heard of croup a lot, but,
Oh, have you?
yeah.
Yeah, I know you guys already had a lecture on asthma and what the incidence is. So I'm just telling you that asthma is very prevalent in children. When you see an asthmatic coming into the emergency department, what would you want to assess?
Debris. I'd want to auscultate them.
All right, so first thing you want to do,
Is their physical appearance.
okay, physical appearance,
Like
including,
tripod or retractions, nasal thing for babies, grunting.
okay, so you go neurostatus first, then you go work of breathing second. Because if you have a baby that's lethargic and not responding, then their work of breathing is normal. It's probably because they've been working so hard and they're at the very end, and they're going into respiratory arrest. So first start off with neurostatus, then go to work of breathing. So with work of breathing, you mentioned retractions, nasal flaring, paradoxing. All right, what else about, how else can you evaluate the respiratory system other than work of breathing?
You can ask them if they're old enough to talk, how bad it is, get your senses.
Okay, so if they're old enough, can they talk in full sentences? Okay, what if they're 6 months old?
Their cry is short.
Can you ask
They're crying. Yeah, like what
If they're
you said.
crying?
The
Okay.
short
Their
cries.
vitals? Okay, so vital signs, looking at O2 stats,
Yeah, that helps a lot.
and breath sounds?
Yep.
And breath sounds, okay. And what sort of treatment would you give an asthmatic?
Should you ask
Doing
the
it.
parents how many, or like if they are diagnosed as an asthmatic, how many doses of their inhaler they took at home?
Okay, so if they've been using an inhaler at home, how many doses do they get today?
Yeah.
Now, if they're on Q4-hour treatments, and they had a treatment already, would you withhold another treatment?
No, not at all.
No, so you would still give it, even if they had it an hour ago or a half hour ago. Maybe it wasn't enough. So while steroids are being put on board, usually I think that's to be started to give the systemic steroids, you can give another treatment. But if the treatment has Atrovent in it, can you give that back to back?
No.
No. So albuterol, yes. You can do Q20-minute albuterol, but you can't do Q20-minute Atrovent. Could you add Pulmicort to the nebulizer
At the same time.
at the same time?
Yeah. Yeah.
You do it all the time? Okay, so yes. So Pulmicort, beta-2 agonists. All right. That's it for this lecture.